That's the other thing. There you go.
So, good afternoon. It's lovely to meet you on the digital world. So it's fantastic. So I'm Kirsteen and I'm chair for the North Highland Women's Wellbeing Hub. And I've actually lived myself with endometriosis for about 30 years now, which has been quite challenging many times in my life. So absolutely delighted to be joined today, and I'll let you introduce yourself.
Hi, Kirsteen. Thank you so much for having me at the Highlands Women's Health Hub and introducing yourself as well as reaching out to me. I'm Dr Nighat. I'm an NHS GP. I live and work around London and Buckinghamshire. I'm a health content creator. I'm an author, so I've written a whole book all about women's health called The Knowledge, Your Guide to Female Health from Menstruation to the Menopause. I also currently head up the Health Collective, which is mapping all marginalised and grassroots organisations that are doing the work in their communities to uplift and also educate in the nuances that their communities understand when it comes to women's health. And that is in conjunction with my charity, which I'm ambassador for, called Wellbeing of Women. And it's a charity that's going 60 years strong, but also funds a lot of the research projects. So what Wellbeing of Women is currently doing at the moment is funding a project looking into dichloroacetate in hope to reduce the growth of endometriotic lesions. It's also partly funded the project for a ovarian cancer vaccine, which I'm very excited about, and also set up and partly funded the online information called vulval lichen sclerosis in conjunction with the British Dermatology. So it looks after from, girls all the way up to menopause and beyond. And the Health Collective sits quite nicely in that because Professor Dame Leslie Regan, who's the ambassador for the Women's Health Strategy in England, also co-joined with me on the collective. And that's been now going 2 years strong. So when it comes to writing policies, we've got the grassroots organisations already primed to help us write up clinical policies, which can then make it into guidance and we're not sort of rooting around in the dark. Other than that, I would say my most rewarding job is I am a mother to 3 boys. I wasn't blessed with any daughters. And my boys, I teach them everything about vulvas and vaginas because they should know from as whenever they're ready to learn. And I have a 13-year-old, a 9-year-old and a 6-year-old. And I think they think that mum's a bit crazy, but that's where if we don't start with teaching our boys at home, where do we start? So it all starts with the mothers. And if I can do that little tiny bit of making sure that we break the taboo and the stigma and the shame around women's health, then that would be like, that's it, I'm done. I feel like my work would have been done by then. Yeah.
That's amazing. I'm a mum of 2. I've got a daughter who's 23 and she's got endometriosis as well. And then I've got a son who's just turned 19. And yes, he's been brought up knowing all things women's health related as well. So yeah.
Great. I'm sure he had it all the nitty gritty at home.
Yes. So it's amazing. So one of the 4 support groups that we've got is the Endometriosis North Highland group. So we put some questions to them. So it'd be really, really good just to sort of touch on some of that areas with yourself today. And it's really good. I think it's really positive that we're having this conversation in April because obviously Endometriosis Awareness Month was last month. And it's always good to see extra outside of March as well. So it's fantastic. But there's been a lot of talk in our group recently about the link of endometriosis with other conditions, particularly fibromyalgia. We've always seen it quite heavily linked sometimes with like adenomyosis and PCOS, but it does seem to be coming through a bit more with like fibro, ME, POTS, all sorts. So just would be really good to hear your thoughts around that.
Yeah, so it's April, which is actually Adeno Awareness Month as well. So it's really nice that we've got that conjunction with each other from March to April. And the conversation should continue, I believe, all year round. So let's look at the data and the studies around endometriosis and what we know so far. I think I've moved away from saying, and I hope a lot of my colleagues have moved away from saying that it's just a reproductive organ disease. Endometriosis is categorically an all-over body condition where cells similar to the lining of the womb, but not the lining of the womb, deposit outside. And this is the crazy thing, is that those cells then behave completely independently with what's happening with your cyclical ovulation and also what's happening in the womb as well. And what we've known from the data so far is that those cells, because they behave independently, become glandular-like. So they have their own inflammatory responses and their own impact on the immune system. In Coventry University at the moment, in Warwick University, there's a colleague of mine who's doing a research project looking at how the inflammatory process, so the macrophages, which is part of our immune system, become impacted by endometriosis. And this is really significant because not only is this that it behaves independently from what's happening in the womb, so the theory of the fact that this is estrogen driven slightly means that we've got to look into that furthermore. So we've always said that endometriotic lesions are fed by estrogen. And the reason I'm saying air quotation mark is because actually we're not too sure. And if it means that there's now inflammatory, it means that there's a direct impact on the immune system. Harvard University also did a meta-analysis of all the data that they had, and they looked at, yes, there is an impact on the immune system, but stopped short of saying it's an autoimmune condition. Where's that link with fibromyalgia? Well, fibromyalgia is deemed as an inflammatory autoimmune condition where your own immune system starts attacking your cells around your muscles and your joints. And therefore, we know that women are far more disproportionately affected. And get this, we already know that women go misdiagnosed with endometriosis for up to 10 years, but we then pick them up with fibromyalgia. So the link between endometriosis goes beyond the fact that this is just the reproductive organ. You've got to look at the impact on the immune system and also the inflammation. Inflammation fundamentally underpins lots of key processes in our body. It means our cortisol is higher. If you have endometriosis, your cortisol goes up, your dopamine is lower, your serotonin is lower, so your recovery system isn't so great. And get this, there's data now showing us that those that are affected by that inflammatory process, their melatonin, so their sleep hormone, is impacted. So endometriosis sufferers who go misdiagnosed because we don't have a conclusive test, and we'll come on to that later, why that is, but we already know that because it's an all-over body condition, it's a lifelong condition. It means it now plays into play with lots of other conditions like POTS, connective tissue disorders, so your hypermobility or ME, fibromyalgia, adenomyosis, where cells from the endometrial lining go into the muscular wall, causing the muscular wall to become inflamed and bigger, bulky uteruses. And I have always insisted and said that adenomyosis is not a disease that happens to women 40 and above. The NHS website is atrocious in that because it says it only happens to older women. But adenomyosis I've picked up in 17-year-olds. So there is a way of picking it up earlier. And also we know that there's a link with endometriosis with, say, PCOS, which again is a lifelong metabolic condition, and fibroids as well, because fibroids is driven, what we believe so far, by that estrogen component of our hormones as well. So it's a multifactorial condition, which also then has its own fingers. So I see now endometriosis, and this is not scientific, but I would say it is like, if you've ever seen the film Venom, and the Venom character spits off bits of its body elsewhere, and then that behaves independently, and there's more like links in like that. It's exactly like that. It is this horrible condition which spindles off in your abdomen like a scattergun, and then goes everywhere else. So we've now seen cases of, say, endometriosis in lung. In America, we've had cases of brain as well. And then it impedes and takes over, I would say hijacks your immune system. The issue that I have is the scientific fraternity don't agree with me on that, because we don't have the data yet to say it's an autoimmune condition like fibromyalgia. And that is where the limitation is still there, and we need better research.
Absolutely. That's really fascinating. And, like, you get to a stage that, obviously now I've had a oophorectomy over a year ago. So now doctors kind of like, oh, well, that's it. It's over.
Yeah.
It's not. So it's really good to see these conversations, that it does carry on post-menopause for some women.
So there was a study that, again, because of the limited studies, there's a handful of studies that have been done globally to show actually no, even postmenopausally, because the myth that we had been peddling for a very long time in medicine is that, and because this is where the data stopped, right, to say that women who then become postmenopausal, because their estrogen naturally decreases, it doesn't feed, again, air quotation mark, feed the endometriotic lesions, therefore the endometriosis gets better. And actually, I've looked at those studies, and there's a big meta-analysis done of that to show that isn't the case. We've been lying to women by saying that menopause means that it stops because the estrogen decreases. And there's a really fascinating pathophysiology that they looked at the histology of the endometriotic lesions in women who'd had a hysterectomy. So women who'd had their ovaries and their womb removed still complained of endometriotic like pain, and they were gaslit or they were ignored and said, no, it can't be your endometriosis because we've just removed the organ which causes all of it. And when they looked back in those women and went in doing laparoscopy, they took endometriotic lesions that had continued to grow. And get this, they found that possibly in those lesions, it started becoming its own estrogen hub. So not only endometriosis continues to grow and act independently, impacting your immune system, causing inflammation, but what it does is we think because it's glandular, it starts producing its own ecosystem of, say, hormones. And that I thought, oh my God, like this is just the tip of the iceberg. So you cannot say to a woman having her ovaries out, so an oophorectomy bilaterally with a hysterectomy, so that is going to cure your endometriosis, because it doesn't. It's a symptom relief to give you life back. For the majority of the women that I look after who have had that surgery, actually it does give them life back. It means that it gives them symptom free. And that's why now I categorize it as a lifelong condition that we need to manage and understand the real pathophysiology of it so we can stop it at its cause. We know that there are genetic factors. So we know even on an embryological level, there are girls, female fetuses who are born with endometriotic-like lesions, and they only activate once they hit their first menstrual period. And that's why the theory of, say, the estrogen came into play. But that doesn't seem to relate into, say, postmenopause in women who've had a hysterectomy. So how can you explain that? Actually, we don't really have the data. So what they did really, as we do a lot when it comes to women's health, is they looked at weight. Now, weight is important, and I say that as a clinician who looks after women's health, because we know that obesity is linked to so many other conditions as well. But what they said is because adipose tissue, and adipose tissue is a really important organ in itself. It's a hybrid of immunological function, endocrinological function, and also produces its own hormones. So we produce a lot of our sex hormones, estrogen, progesterone, and testosterone through our fat cells, so our adipose tissue. That's why women, we are slightly more curvier than, say, the male structure. And that's good fat. We need it because it helps our bone, looks after our heart, looks after our brain health, stops us from getting osteoporosis. So what they said is that women who have endometriosis, well, it's because they're bigger, it's their weight to blame. And that is utter rubbish, because you've not thought about the fact that it's not anything to do with the weight, because you get very slim endometriotic patients who have just as horrific disease. But again, I feel that saying to somebody, oh, lose weight, or it's your weight that's going to be a factor, is a way of fobbing them off. Obesity is a different thing. Obesity is a chronic disease, and that needs its own management because it has its own metabolic processes. But the interplay of, say, just normal weight and endometriosis is a really interesting one, and I think another one that is linked with a lot of shame and taboo, and we need to unpick that quite a lot and understand that pathophysiology of adipose tissue on endometriosis, which we don't have great amount of data for either.
Yeah, it's really interesting that you touch on the weight, because it's so difficult to exercise when you're
emotive. It's so emotive. It's so difficult to exercise, and you're almost shamed. And I refuse to believe a woman or a girl isn't, from a very, very young age, the moment she has consciousness, isn't told about her weight. I'm sorry, but that's a global universal truth that we still haven't had that national conversation about. And I would say that that has skewed into the male gender as well, but far more it is intrusive in the female gender.
Yeah. So sticking with research, it's really good to see so much more coming about in all different areas. There's some fantastic work going on in all the nations, which is really good to see. So the Expect team in Edinburgh just published a new one last week, and it was looking at sort of the gut and the sort of impact around sort of caffeine, alcohol, and gluten. And it was funded by one of the independent groups in Scotland, Endometriosis with Lothian. So there's quite a lot of independent support groups in Scotland, and we do quite a lot of work together, and we do work with the Endometriosis UK ones as well. But it's amazing a community, but it's amazing, that they funded this to be done as well. So it'd be really, really interesting to hear your thoughts, because obviously we do know that caffeine and alcohol does come with a lot of disadvantages.
Yeah, and I come back to that inflammatory processes again. So alcohol, ethanol in that, the liver has to process that. And we know that that also plays havoc with your serotonin, which is your happy hormone. So it gives you that initial ease and makes you feel quite jolly, actually. Alcohol, that's why there's a limit to alcohol. And then after that, on top of that, it actually becomes detrimental because your liver is trying to get rid of this ethanol toxin from the liver, and stops what else it's doing. Other medications that you might be taking alongside your alcohol consumption means that that medication might not be having the positive effect that we want it to do. And then also what it does is it increases your cortisol level after a limit of alcohol that you've had. So the recommended amount is 14 units for men and women. But we know that those that have, say, already higher cortisol levels or metabolic syndrome or inflammatory processes like fibromyalgia or endometriosis, that we say limit it to the bare minimum if you possibly can. But I totally understand, as humans, we are fallible. And for a lot of my patients that I look after, alcohol is actually their way of self-medicating. So there's an underplay of, so I have a great empathy for people who do that, because that is the crux or the learning mechanisms that they've found that. Because historically we find that women have been so gaslit, so ignored, that they're left to their own devices at home, because they go to the doctor, the scan says everything is normal, and they're told it's all in your head, darling, go home. And so, if you saw your mum in agony every month and she used alcohol, it's learned behavior that we pass on and on and on in generations, and we see that time and time again. The interplay with gluten is really interesting, because we already know that gluten can trigger off celiac. Celiac, again, is an autoimmune lifelong condition in the small bowel, which causes inflammation because you get an allergic reaction to the gluten. So it's a very, very serious condition, and again, has its own pathway and treatment plan. And I think, again, that shows that the immune system is reacting against itself. And then if you look at, say, other food sources, which again will trigger it off, is the high ultra processed food diet. So, it's your burgers, it's your bacon, it's your ham, your salami. All those ultra processed foods already means that that's going to impact on the gut. And we've seen that, because wherever the gut is impacted, so you don't have enough fiber. So fiber is vitally important for the rejuvenation of keeping the stools nice and soft. As a nation, we have very starchy food. As a nation, we don't drink enough water, so about 2 liters a day is important. And all of that is going to impact on your gut, because your gut does need to empty itself every 24 hours, or I would say even twice within those 24 hours, because it needs to make sure that it's rejuvenating. And as a nation, we are constipators. So we're quite, I would say, stool retentive. We like to hold on to our poo. And that is because we just don't have the best diet. And I say this as someone who comes from a level of privilege. Not everybody has that level of knowledge and understanding. So I think there's a real lack of understanding when it comes to, say, ultra processed foods, because you think, if I think of a lot of my parents, like my parents and the patients that I'm looking after, they are making the best choices for their children and for themselves based on the education that was passed to them. And we never had all of this research and knowledge and understanding that we do now. We never had social media to play a part in it as well. I never really understood the impact of, say, sugar or numbers that we do now. And that, again, plays in how our immune system is able to cope and rejuvenate our gut. And if you've got endometriosis, your womb physically sits in amongst your gut. So we already know that endometriotic lesions go out into the bowel as well. So there's a close link with endometriosis and say celiac or Crohn's or inflammatory bowel disease. And that is because it's all, not all the same thing, but it's that intersectionality of the diseases that come together. So diet really does underpin a lot of what your gut is doing, and also what your brain, because we've got the vagus nerve, which talks to the gut brain axis, talks to each other, because we've got a lot of GABA receptors in our gut, and then we have GABA receptors in our brain that communicate with each other. So we produce about 95% of our serotonin, our happy hormone, in our gut. A third of our immune system sits in our gut. So literally what we eat is going to influence our mental state and mental health, and then how our immune system interplays with that, with the cortisol level, which we know is already linked to, say, a lot of inflammatory processes. And the thing that I always worry about when it comes to diet, and I'll just round this off on this point, is that it's important to understand the interplay of nutrition is different from, say, diet, and is different to, say, supplements, because there is no diet that will cure your endometriosis. Yes. And unfortunately, I see that a lot on, say, social media, and the misinformation. Eat this radish, or take my supplements, and your endometriosis will get better or go away. And I think that is really damaging, because it plays on that vulnerability factor of someone who's desperate to get on with their lives. And that's what women and girls want. Like, they literally just want to get on with their lives, do their job, put food on their table for their families, a roof over their heads. It's the basic necessities, but our menstrual health impacts that. And unfortunately, we've really got to call out individuals who offer diet as the only management plan when it comes to, say, chronic diseases.
Yeah, absolutely. But yeah, it's really amazing to see all these new research projects through, and they are doing an incredible job, and expect, and we're really lucky to work alongside them as well. So another area that we see talked about quite a lot is like the effect on bone density with GnHR analogues and long-term sort of contraceptive use. It would be good to sort of know your views on that.
Yeah. So I would start with the point that we already know that endometriosis is a lifelong inflammatory condition. There is no cure for it so far. So the treatment options, as per the NICE guidelines for endometriosis, and if anyone didn't know, yes, we do have NICE guidance for endometriosis. They're not the best, but it's what we have at the moment. And it offers, I would say, what are management options. They don't actually treat anything. So if we offer you the oral contraceptive pill, it's really because we want to stop, I say air quotation mark, the shedding process. Although we know that that's not only the reason why you get endometriosis, but it means if we can stop the ovulation and the periods at the same time, it can give you some relief. But what, again, the data has shown that it doesn't stop the progression of the disease. It just puts the symptoms at bay so you can carry on with your life. But actually, the data, again, has come back to show globally that you probably could go from stage, say, 2 to stage 4 whilst being on oral contraceptives. And that, I think we still need to get our head around that. And I educate my patients a lot with that and say to them, but this is really because I don't have a cure. And it allows you to plan for your fertile years, because it depends where you are on your fertility journey. A lot of my patients, they dream of having a family, and why not? Like, that is totally your choice. Some of my patients are like, they choose to be child-free. Absolutely, another completely individual choice as well. So as a clinician, I'm trying to support that. Then if oral combinations aren't going to be great, then you might want to consider a LARC, so long-acting reversible contraceptive. That could be the implant, that could be the injection in the bottom, or the coil. So the Mirena coil, 52 milligrams, levogestrel Mirena coil, or Benelixia, or Levocert. So we've got a couple now on the market. That what it does is, because it's physically in the womb, suppresses the lining, decreases ovulation. So what is the link between, say, longer term effects in regards to bone density? Well, we know that we try and get people to have breaks. So if they're on a fertility journey, they're going to get that natural break as well. So younger women, we know, have high levels of estrogen naturally anyway. And so we encourage them, if they're going to be on an ovulatory suppressive medication, to take vitamin D, calcium, do weight-bearing exercises, resistant exercises, don't smoke, don't drink too much alcohol, keep an eye on your family history and your weight as well. So being underweight, so your BMI is below 18 or 19, puts you at high risk of reducing your bone density and high risk of, say, osteoporotic fractures. So being a healthy weight, which obviously I know BMI is not accurate, but being, a healthy weight is really important. Conversely, what about the other side as well? Because we don't know whether endometriosis impacts bone density yet. Some studies show that actually it does because of that inflammatory process, and some studies show actually there isn't a significant enough link with endometriosis, even if you're not on contraceptives at all. And then finally, at the end, the sort of the last stage management, when someone is done with their children or their fertile years, and they might have a hysterectomy, then the idea is that we can give add-back hormone replacement therapy, HRT. So even if you keep your womb and you've got endometriosis, hormone replacement therapy is still important, and it's first-line treatment as you progress into your biological transition of perimenopause, menopause, which is defined as 12 consecutive months without a period, and postmenopause and beyond. But what you need to do is counterbalance that when you're giving estrogen, because that might grow the endometriotic lesions, with a good amount of progesterone. So by giving the estrogen back into the body actually gives you the bone density protection. And then consider those that are the higher risk. So the way that we do that is we do a FRAX score. So anyone listening to this, I would say if you are in your perimenopausal years, so you're 45 and above, you can go online and there's something called a FRAX, F-R-A-X tool risk assessment. You can do that online. You don't need to see a doctor to do this. And you put in your date of birth, and then it goes through a number of questions, and then you get a graph showing you what is your risk of having an osteoporotic fracture based on that. Because it's not just the fact that you might be on, say, contraceptives that are going to put you at risk of that. Because we already know that contraceptives might actually be beneficial in regards to reducing that inflammatory process and allows you to exercise and therefore carry on with your life. But actually you could, say, have asthma alongside your endometriosis, and you might be on steroids for that. Now that's going to have an impact. You could be having fibromyalgia. We could be managing your fibromyalgia with, say, prednisolone or steroids. Again, that puts you at risk of, say, osteoporotic fractures. So you've got to take this all over holistic view. But I would say two things for bone density. Start looking at your FRAX score. Do it, I would say, once a year. You can go online and do it. And a lot of people don't know about that. And then at your HRT review, have a discussion with your doctor. And if your FRAX score gets you into the intermediate risk, go for an early density scan. And then depending where you are on your biological journey, if you're approaching perimenopause, and considers hormone replacement therapy with the protection of the progesterone component sooner rather than later.
So fantastic. It's really good to see you talk about HRT as well, because it's something that's talked about a lot, and there is a fear over estrogen.
Yes. Yeah, I think we've made women so scared of it, but the British Menopause Society have got a very good page for endometriosis patients and hormone replacement therapy, and the Women's Health Concern as well. So if you go on their patient side, because they've got a professional side and then they've got a patient side bit of the website as well about endometriosis. But again, this is old information that's hanging on, that's telling women you can't, just because you've got endometriosis, is contraindicated. Now you cannot have hormone replacement therapy. But that's not true, because hormone replacement therapy isn't the old oral synthetic hormone anymore. We've got very like for like, so what are known as body identical hormones made out of root vegetables and yams, which are made, estradiol, which is very similar to what your ovaries produce, and they come as patches, gels, and sprays. And now we've got a progesterone component such as utrogestan or the Mirena, which can be used. So the utrogestan is body identical, again, root vegetables and yams, reduces your risk of clots, suits very, very well for my endometriosis patients, and that's systemic HRT. It could be the Mirena, which you've already been using as management for your, say, endometriosis, and now that will just play its part in regards to managing your HRT component later on in life. And then also women who've had their ovaries and womb removed, they're now in surgical menopause. So surgical menopause off the back of a background of endometriosis needs its own management plan, say with estrogen, progesterone, and testosterone, because the minute we remove your ovaries and you go into surgical menopause, 50% of your testosterone goes. So testosterone is a vital hormone for our brain, our bone, our cognitive function, our energy levels. So again, it's having that sort of nuance as a clinician to understand that interplay of what we need to add back to the woman, but protect the endometriotic lesions at the same time. And topical vaginal estrogen, such as Vagifem or estriol cream or Vagirux or Estring, that is so low dose if used twice weekly that actually doesn't have any systemic uptake. And so we've seen that it doesn't impact the endometriotic lesions. The only place and the only individuals you have to be very careful with, and this is extremely rare, but I know it does happen, is those that say have endometriosis in their vaginal cavity. So, you know, that is rare.
Yeah.
But if you do, then you've got to be very careful, and that person might not be able to have that level of, say, vaginal estrogen. But it could be that they have systemic estrogen.
It's fantastic, and it's great to see so much more choices become available as well. It's really important. We've seen sometimes, you know, obviously women are waiting so long for diagnosis, and you quite often get to a stage that you kind of doubt yourself. You think it's maybe in your mind because that's the way that you've been made to feel. And then you finally get a surgery date, and the fear is there, what if it's not? And sadly, for some, they don't get a diagnosis first time round. Sometimes it's second time round. And it's really, really difficult because it has such an impact mentally, because you've been for such a long time and then you don't know where to go. And it's really, really hard. What would you say for those women?
The reason that is so hard to diagnose is because although laparoscopy is a gold standard, we need the person doing that to be just as well trained. So just like I'm a GP, I'm a jack of all trade, master of nothing. I then went away and trained in women's health. I'm not an expert in endometriosis, but I have a keen interest in that area as part of my women's health because I deal with a lot of it and it's clinical experience for over a decade that I've been looking after these patients. It's the same with gynecologists as well. You become a general gynecologist and then you become a gynecologist who's endoscopically trained to do endometriosis. And we have an organization called the BSGE, and there are very few registered BSGE specialists in the country as a whole. And then you have to be in a BSGE registered accredited center, which again, there are very few because the NHS has a huge issues with funding, that level of sort of support and the intrinsic amount of complexity with the surgeries, because laparoscopy does come with its risks. You need a general anesthetic. Then if you've got all the individuals in the right place, you're at a BSGE center, you've got a BSGE registered endoscopic gynecologist, his or her area of expertise, then they go into the abdomen and the endometriosis lesions are not there. And that's because the endometriotic lesions appear in different colors. They appear as clear, white, brown, tan, red. And so if you've been trained just to look for, say, red, you're not going to see clear. And if you've just been trained to look for, say, you know, white or red or black, then you're going to completely miss some of the other ones. It could be hidden behind the bowel somewhere because the bowel is huge. It's an absolutely huge place. So you look in the usual suspects. You look at the bladder, you look at the ovaries, you look at the fallopian tubes, you look at the uterus. But actually, it could be so sneaky. It could be somewhere else. It could be on the bowel. And that's why then you need a trained endoscopic surgeon who doesn't just do it by sight. They take biopsies, which again come with their own risk of bleeding and complications. And then those biopsies are categorized from the lab who's able to look at them. So you need an endometriosis pathologist who's able to specifically look for, say, clear endometriotic cells. So do you see the level of intrinsic barriers that we've got? And that is why when women go in for their operation, they come round and the surgeon goes, Well, it looked absolutely fine. It didn't look like you've got endometriosis, and you feel almost disheartened because by that point you've lived with your symptoms for a decade, that you think it's not in my head, it's got to be something because I am living with this. So I think what I've come to a conclusion as a clinician, because a lot of these patients then get put back to the GP to go community medicine management, we've done all of this is her pain meds, this is her hormonal therapy that she needs to go on and manage her in the community, but we can't find it, is I still categorize them as endometriotic patients. And the reason that is so important, by making sure you put that in the notes, and it's all to do with funding of care, because every single time on the NHS, when we code a patient with endometriosis, it gets flagged up, so the national numbers, so it tells us that we've got patients, but also flags up the national numbers who we think have endometriosis, but normal scans. So we cannot rely on a normal ultrasound scan, a normal MRI, a normal laparoscopy. We believe the patient. So that's really important, because it means that our tests are failing the women. And then finally, it means that we can then grab the database to say, please put endometriosis in a quality outcome framework, QOF. Once you have a quality outcome framework for a condition, it means that there's a recall system to get those women back into your clinics, and then there's a funding behind that, and time of the clinician, making sure we've got enough clinicians trained up in that area, and also making sure that we've got enough treatment options for the patient as well. But at the moment, the majority of women's health, such as endometriosis, isn't quaffed. So it's all then falls back on the patient to be an advocate for themselves, which can feel like, depending on what area you are, like you're pulling your hair out and you feel like you're not being listened to or told that it is in your head. And that is why we are where we are when it comes to women's health in this country. And we have started now making sure that we're really hitting hard with the women's health strategy, and that at the moment is only in England. Scotland and Wales aren't part of that, and I'm desperately trying to make sure that it comes into the four nations, and Northern Ireland as well, because the situation in Scotland, Northern Ireland and Wales, from the stories that I hear, are just utterly tragic. It's so dire.
Yeah, absolutely. I think there'll be a lot of women that'll be really touched to hear you say that. And we're really lucky because we have some amazing practitioners out there like yourself who are beating a drum and raising awareness and properly hearing us and seeing us, and just unbelievably grateful for your time today. And I know you're up against the clock, so I'll just wrap it up now. But thank you so much. Women's Hub and the 4 support groups are run by myself, Rebecca and Claire. We do everything voluntarily, and we just really, really, really appreciate that you've taken the time for us. So I will stop the recording. So thank you.
No, I'm really proud of you for all your work. I want to map, you've emailed me, but I want to map the work that you're doing and put it on as part of our collective.